So good morning and welcome back to this term's series of Grand Rounds. For those who don't know me, I'm Ashok Handa, one of the vascular surgeons and the Director of Teaching Surgery. I'm really pleased to welcome colleagues from vascular surgery today, and the title of the talk, Novel Endovascular Strategies for the Treatment of Venous Thromboembolism. I'm delighted to introduce Dr. Andrew Wigham. He was appointed as a consultant interventional radiologist in October 2014. He's the interventional radiology lead for deep venous service at Oxford University Hospital, which is a relatively new service. I say that, although it's coming up for about 8 years, I think. And so relative in that long view. He completed his training at Imperial College School of Medicine, gained an MRCS in 2006, before then training in interventional radiology. He completed that training at the Royal Free Hospital in London, and he regularly presents on the management of both acute and chronic venous disease, both at national and international conferences. And I know that both Miss Wilton and Wigham have just come from presenting on the plenary sessions at the International Charing Cross meeting earlier this week. So I'm particularly grateful that they've come straight from Charing Cross yesterday evening to our Grand Round today. So the stuff they have to tell us is hot off the press. The second speaker today is Emma Wilton. She's a consultant vascular surgeon and also the clinical lead for vascular surgery. She was appointed here in Oxford in 2017. She's not just the clinical lead for the Department of Vascular Surgery, but also the surgical lead for the deep venous service. So a great pleasure to welcome you both.
So thank you very much for asking us to speak today on novel endovascular strategies for the treatment of venous thromboembolism. So why do we want to treat acute DVTs? So we want to treat them in order to prevent and to treat complications of chronic venous disease due to acute iliofemoral DVT or chronic venous outflow obstruction. So the annual incidence of DVT is about 1 in 1,000 people per year. The main complications being post-thrombotic syndrome. So this affects approximately 30 to 50% of patients with a DVT, and approximately 10% of those will have severe post-thrombotic syndrome with ulceration. Post-thrombotic syndrome has a significant impact on quality of life. These are just some pictures of our patients. So post-thrombotic syndrome is a collection of symptoms and signs, which I've listed here. It has significant psychological symptoms, including depression, anxiety, and loss of confidence. So these patients are often young, and can have a significant impact on their quality of life. Post-thrombotic syndrome can be measured as mild, moderate, or severe, and we have various scoring systems in order to determine this. It causes a lifelong healthcare burden, and therefore there is a health economic benefit to treating these patients. There are some risk factors that have been identified at trying to determine those patients that will develop post-thrombotic syndrome. So we know that a proximal DVT is 2 to 3 times more likely to develop post-thrombotic syndrome. Age is quite interesting. So it used to be thought that the older the patient, the more likely they were to develop post-thrombotic syndrome. However, recently there have been papers suggesting actually that younger patients are more likely to develop it. And a higher baseline Villalta score at presentation also suggests you're more likely to develop post-thrombotic syndrome. There are some symptoms and signs as well during follow-up that would suggest you're going to develop it, such as persistent venous thrombosis on duplex ultrasound at 1 month. However, historically, the window for treating patients with acute DVT was sort of 2 to 3 weeks due to the effect of thrombolysis on clot. So there are some arguments against endovascular intervention for acute DVT, such as lack of evidence. It's not limb or life-threatening in the majority. However, it does cause a significant physical and psychological impact on this young patient cohort. The cost of devices and treatment is often raised as a concern. However, compared to the significant impact on these patients' lives going forward if they develop ulceration, there is a cost benefit to treating it. The average NHS cost of wound care over a 12-month period for a patient with a venous leg ulcer is £7,600 per venous leg ulcer. So we could potentially manage these patients conservatively and intervene on those who develop severe ulceration or post-thrombotic syndrome. However, this is a flawed strategy. The quality of the inflow vessels is vital for long-term stent patency, and the longer, if you don't treat them acutely, this is more likely to develop. And more extensive stenting is often needed again in chronic venous occlusions. So there have been some studies. The Cavant study, the 5-year data came out suggesting that there was a benefit for catheter-directed thrombolysis at 5 years versus anticoagulation alone. The ATRAC trial, which there's been a lot of debate about, the headline finding from this was that there was no benefit in endovascular treatment. This was a large randomized trial, but it doesn't reflect current practice. They included both iliofemoral DVT as well as femoropopliteal DVT, and they had a binary outcome. There are 56 centres in the US that were involved in this, and they only randomised 1 in 40 patients. The CAVA trial as well had a very low technical success of crossing the lesions. So none of these previous trials reflect contemporary venous practice. There are some more up-to-date trials, such as the CLEAR DVT trial, which was presented at Charing Cross. This was 35 patients undergoing pharmacomechanical thrombolysis, and the 12-month follow-up showed no post-thrombotic syndrome in 96% of patients and mild post-thrombotic syndrome in the remaining 4%, so very promising. The CLOUT registry is the registry for the Inari ClotTriever device, and the 6 months data that was presented at the American Venous Forum showed that all groups with acute, subacute and chronic thrombus had low rates of post-thrombotic syndrome. Obviously, ongoing data is being collected for this. So there are various different mechanical thrombectomy devices that can be used. Mechanical thrombectomy we use, and we've changed our practice towards this in order to minimise hospital and HDU stay. So NHS bed pressures has significant impact on practice. Obviously, arterial work tends to take precedence over venous work, but we can potentially do these cases as day case procedures. As I mentioned earlier, the cost of the device has been raised as a potential concern. However, the cost of treating patients with thrombolysis and needing an ITU or one-to-one nursing, and the time of the returning to the operating theatre or the interventional suite, including the staff cost and the cost of the actual lytic agent itself, the alteplase, actually there's a balance to be had. Thrombolysis also carries a risk of bleeding. This can be from the access site, and also the main concern is obviously intracerebral bleeding. And you get more effective thrombus clearance with mechanical thrombectomy. So lysis-related hemorrhage, as I was saying, is a concern. So intracranial hemorrhage is potentially a catastrophic complication, particularly in these patients who can be relatively young. You can get visceral bleeding and access site bleeding, and we've certainly had complications of that in the past. The risks do increase with the older that you get and the length of the period that you're running lysis for. This is a picture of the CT scan showing one of our patients who had an IVC and iliac vein thrombosis and had thrombolysis running for 24 hours, went back to the interventional radiology suite. There was still thrombus there, so we ran it for another 24 hours, and she developed this left subcapsular renal hemorrhage. Obviously, everything had to be stopped. We were unable to anticoagulate, so a complete disaster. The reason we're talking about this is thrombus morphology. So clot forms initially with red blood cells and platelets. Fibrin deposition occurs at around 7 days, and then fibrin predominates, and then you begin to get collagen deposition. So a significant proportion of our patients, however, present after about 3 weeks. So although they may give a history of a week of symptoms, actually, when you go back, 70% of patients that undergo intervention, you will find that the clot is not acute and is more subacute or even chronic. The reason patients present later is a lack of awareness of what we can do, so a lack of awareness of endovascular treatments. It may be an ascending DVT, suboptimal referral pathways, particularly around the UK, patient choice and difficulty scheduling cases. So these pictures show, the top picture shows a very acute thrombus, whereas the picture underneath, which you can't see very well, shows picture down below shows more chronic clot. So mechanical device thrombectomy device options. There are various different devices that you can use. So the Inari ClotTriever and FlowTriever is a purely mechanical device. There's an aspiration thrombectomy device by the Penumbra Indigo system, rheolytic thrombectomy by the Boston Scientific angiojet device, ECOS, which is you use with thrombolysis, so it's ultrasound accelerated thrombolysis, and the BD Aspirex rotational aspiration device. So in our practice, thrombolysis is becoming obsolete in the primary treatment of veno-occlusive disease. So the newer devices have enabled us to treat patients in a single sitting, and we're able to schedule these cases better. So there's effective removal of more organised thrombus in is a significant step forward. So we can increase the cohort of patients that we can treat. So we're treating patients out to sort of 6 weeks and even potentially beyond. We've reduced the bleeding risk, and we're able to schedule cases in a far better way. We are also able to see patients, assess them. If we're not quite sure whether we think they're going to benefit from treatment or not, we're able to bring them back in another week or even 2 weeks and still intervene if necessary. So the table or the graph shows our current data. So from 2014, our practice was mainly catheter-directed thrombolysis with some pharmacomechanical thrombectomy. And you can see from 2020, when the Inari ClotTriever device and mechanical thrombectomy devices were more available, that actually for the last 2 years, we've done no lysis cases at all and a purely mechanical thrombectomy. So for acute DVT, who are we going to treat? So we are obviously going to treat patients with phlegmasia or those with significant moderate or severe symptoms with minimal improvement after conservative management. You do need to consider age and comorbidities. However, there is no cutoff, either very young or very old, that we would use. It's a patient-by-patient decision. So we treat iliofemoral and IVC DVT. The patients do need to be compliant with anticoagulation, and there is a very strict post-procedure anticoagulation and follow-up schedule, and the patients need to be aware of this, and we need to feel that they are going to be compliant with this. Currently, we don't routinely treat isolated femoral and popliteal DVTs. So the procedure itself is thrombus removal by whichever method, plus intravascular ultrasound, venoplasty, and iliac vein stenting if appropriate. So we do it in a single sitting. There's a reduced bleeding risk and length of hospital stay. All the patients have TEDs and floatrons put on before we start the procedure. They get intraoperative heparin with an ACT maintained at over 250 throughout the procedure. The procedure can be performed under either local or general anaesthetic, slightly depending on patient factors. We have done them as a day case procedure. And as I said, we do have a very strict post-procedure anticoagulation surveillance scan schedule afterwards. We also have, or there needs to be a pathway for these patients as well, if there are any stent-related problems, to come back into the system.
Thank you. So just going to look at a couple of cases to highlight the points that Emma illustrated about how the advent of mechanical thrombectomy has significantly changed our practice. So the first patient, this is a 44-year-old lady with an extensive history of thrombosis and was on long-term dabigatran. She'd recently undergone a calf debridement following a spider bite. And that was in this country, apparently. And she had then had a period of immobility as a consequence of the debridement, missed 2 doses of anticoagulation, then developed severe leg swelling 4 weeks before we saw her. So initially, we would have said 4 weeks. We've missed the boat for treatment because thrombolysis, as Emma said, is basically only effective up to 2 weeks. She basically couldn't walk. She had severe swelling, and her debridement wound wasn't healing. And we can see on the CT there, we've got a very swollen leg and more chronic thrombus in the left iliac vein. These are our initial venograms. So we can see the femoral vein, which is the vessel here, is chronically damaged. And this is from her previous DVTs. And we've got axial transformation of her profunda vein here. And the pattern of the thrombus in the iliac segment is more organized in that it's not completely expanded. The vessel's starting to contract. So for this, we use the ClotTriever device, which we can see here is basically a mechanical, or it's a nitinol basket that we drag down, and we've cleared the thrombus there. So you've got a clear iliac vein. That's in 4 passes of the device. What we then need to address is the profunda vein, which is the key vessel for her. So again, we can see the device being pulled back in the middle image through. So that's the basket being dragged through the profunda vein, and that basically essentially drags the thrombus out. And then you've got a clear profunda vein, the image on the far right. There we can see the venogram showing the profunda vein is now clear, and then we're in a position to stent the underlying stenosis in the iliac segment. And she did very well following this. And this is the device on the table. So you can see it's essentially a coring element at the top with a long, flexible bag, and that's the thrombus that you extract when you pull the device through the clot. Second patient we're going to look at, this is a 15-year-old lady, and I think we probably all agree no one's typically very keen to treat 15-year-olds, and we'd all be very reluctant to thrombolize a 15-year-old, albeit they are probably at the lowest risk of thrombolytic complications. The potential of a bleed is disastrous. So she had a 3-week history of leg swelling and pain, and was only able to mobilize with crutches. We tried to manage her conservatively with anticoagulation, but a week later she represented and was still not mobilizing normally. So on the MRI scan there, we can see left iliofemoral DVT. So what we're able to do here now is, despite essentially delayed presentation and a relatively high risk patient in terms of potential for thrombolytic complications, on the venogram, the femoral vein, common femoral vein, and iliac veins are occluded, and this is intravascular ultrasound, just showing it's essentially the same as percutaneous ultrasound in that the more echogenic the thrombosis, the older it is. So we can see from that it's relatively old organized thrombus. Again, we use the clot triever device, and we can see from that first image we've nearly completely cleared the thrombus. There is a mild stenosis. We put a balloon up there. Traditionally, we would probably stent this, but I think we'd all agree that we don't want to place a stent in a very young patient if we can avoid it. And what we're able to do here is on the IVUS now, we can see this lumen is essentially clear of thrombus. We balloon this segment, and then we get good flow, and follow-up ultrasounds only demonstrate a minor stenosis in the common femoral vein, but her symptoms have resolved. She's not got a stent, and she's on anticoagulation as for a normal provoked. Third case, 66-year-old man from Russia. 8 weeks prior to seeing us, he'd undergone an ORIF for a hip fracture. He'd had an IVC filter in place for a number of years. We're unsure of the initial indication, and he had severe bilateral leg swelling. So we can see on the CT here, there's the filter, and basically it's thrombosed down both legs from below the filter. There's our venograms. So we've got clot in both iliac systems. And again, we wanted to use the clot triever device, but given his presentation, this thrombus is organized. It's not going to be lytic responsive. So it's a slightly more complicated solution here in that if you open that coring basket of the device around a filter, obviously you're going to snag on the filter. So we place a long sheath through the filter, then perform our thrombectomy. There's the coring element of the device, and there it has been pulled back down to clear, as we can see on the final image, clear the iliac vein. The issue then is you've got to clear the thrombus in the filter, because that's the sort of nidus, or that's the starting point of the thrombus caudally. So what we use here is a different device, which we'll touch on in the PE section. And this is eventually a 24 French large bore aspiration thrombectomy device called the flow triever. So you place it, you apply high power suction, and then it essentially sucks the thrombus out. So this is an intravascular ultrasound, and you'll see in a minute the suction's applied, and then the thrombus disappears. So that's how you clear, another option for clearing thrombus in larger vessels. And then we can see we've got really good flow. We go back 2 weeks later, take the filter out, no stents, no underlying stenosis. And I think that's what we should be driving towards, is more effective thrombus clearance and avoiding the need for stents, if that's all possible. And this is our data for using the clot triever device. I think we're probably we have the largest experience in Europe at the moment. That's been performed a lot in the States, but we've done 38 patients, median age of 52. One of the key points is the median age of thrombus, which is admittedly not entirely reliable in that it's based on history, but that's not the only way we can do it at the moment of 14 days. And that as we said earlier, we would typically or previously regarded patients with 14-day-old thrombus as almost too late for treatment. We're able to do half of these patients under local anaesthetic, which is very important. None of the patients received an additional lytic infusion for the primary procedure. We get very good thrombus clearance. Nearly a quarter of our patients were not stented, and I think there is a signal that with more effective thrombus removal, we don't need to stent as much. Primary patency 84 and our secondary patency 97, and importantly for a new device, no device-related complications. And this is just showing sort of the data as we've moved through our experience in that the age of thrombus, there is a trend of treating older clot. And I think that is as we get more comfortable with the device in which patients we can treat, we are more aggressive with treating older thrombus. And in terms of procedure time, again, we can just see a trend. Obviously, there are outliers, but as you get more adept with the device, your procedure time goes down, your screening time parallels this line here, which is again important in a very young patient cohort. You don't want to irradiate them if you can avoid it.
So for the acute DVT, the deep venous service, we have set up a team of people. So we have obviously myself as vascular surgeon, Andy as the intervention radiologist. We work very closely with our haematology colleagues to enable these patients to get the best possible outcome. The vascular lab are very important to us, so they do all our post-procedure scans and surveillance scans. Vascular nurses are very important to help us with our follow-up. We also have developed a dedicated venous multidisciplinary team where we meet regularly once every 4 weeks to discuss all of the deep venous patients, both acute and chronic, as well as the upper extremity DVT. So we're also very lucky, particularly in this trust, to have a thoracic surgeon, Francesca Di Chiari, who also attends this for the upper limb patients. We've worked quite hard at trying to improve our referral pathways and promote the service so that to allow patients access to effective DVT treatment. So we hold a regional meeting, annual meeting, to try and encourage people and to educate various different groups of people about what we can offer. We've also developed an acute DVT pathway on the ORS system so that anyone in our region or beyond can refer us acute DVTs that they would like consideration of intervention. I think education is very important. So when we started, it was really important that everybody was on board with what we were doing and educating all different specialties, including primary care, other specialties, our own specialties, pharmacists. So our pharmacists, particularly on the vascular ward, have worked really hard to ensure that the patients have the right anticoagulation and that they go home with the right anticoagulation. The DVT clinics and anticoagulation clinics have also been involved in setting up the pathway so that everybody is aware of what we're doing and the very strict anticoagulation protocol post-intervention. Our network hospitals, so both the vascular network, and we actually take acute DVTs from way beyond our own vascular network because this treatment isn't offered in a lot of DGHs, whereas we can offer this intervention to appropriate patients. This is just a summary of our patient pathways at the moment.
Right, so we'll move on to PE now, a bit more medical. So PE, the annual incidence of PE is 100 per 100,000 population per year. It's the third leading cause of cardiovascular death with very high mortality rates. If we contrast PE with MI and look at STEMI and the treatment of this, if we see since the introduction of endovascular techniques for treating STEMIs, there has been a significant reduction in mortality over this period, so from 95 to 2015. A similar thing we're seeing with stroke now with the management of thrombectomy for stroke. But if we contrast that with PE, the all-cause mortality at 30 days has remained relatively static. There hasn't been any real significant advancements in its treatment despite its high mortality. In massive or high-risk PE, which depending on which definition you use, the mortality can be up to 50%. Intermediate high risk mortality rates up to 6 to 15%. The pathophysiology of PE and what kills people and what we're aiming to treat is right ventricular dysfunction. And we can see on that CT there, gross right heart strain with an elevated right ventricular, left ventricular ratio. What essentially happens is you get increased right ventricular afterload, right ventricular dilatation. And if this cycle isn't reversed, you end up with left ventricular dysfunction and ultimately shock and death. And this is the target for treatment in PE, is the right ventricular dysfunction. So the classification systems are important. So high risk, this is the ESC classification, is defined as having hemodynamic instability with right ventricular dysfunction and elevated cardiac biomarkers. Intermediate high risk, these patients are outwardly stable but have underlying right ventricular dysfunction with elevated markers, and these are potentially patients which will deteriorate. Intermediate low patients are stable with no right ventricular dysfunction, and these require anticoagulation and nothing more. And it's the same with the low risk category. So stratification is really important at an early stage. To comprehensively stratify people, it's important to also look at other things. So we have various other markers which can predict poor outcomes. So lactate is thought to be becoming increasingly important, in that a high lactate may be predictive of poorer outcomes. We have to look at patients' bleeding risk. A large proportion of these patients are post-op, so they have contraindications to lytic. We have to look at age, underlying cardiorespiratory disorders, all of which should be incorporated into assessment and deciding which treatment is most appropriate. The options: anticoagulation, systemic lysis, and it's worth noting that the data for which systemic lysis as a treatment is based on an 8-patient study from South America. Catheter-directed thrombolysis, which we used to use quite a lot, and that was essentially putting thrombolysis catheters into the pulmonary arteries and leaving them, and the idea being you need a lower dose because you're delivering the lytic straight into the thrombus. You can put an IVC filter in. My personal opinion is they don't do anything. Surgical embolectomy is an option. ECMO may be required for certain patients. We unfortunately don't have ECMO on site in Oxford, but we can get patients on ECMO. And then we have percutaneous mechanical thrombectomy. And again, the considerations. So how stable are they? What are their bleeding risks? We have absolute and relative contraindications. We need to consider treatment escalation. This is really important. So if they don't improve on anticoagulation or they don't improve following lytic, then we have to escalate our treatment. We need to think about age of thrombus. So Emma talks about age of thrombus in DVT, but we have to remember that in PE, the thrombus will have come from a leg or an iliac vein. And if that's been there for 3 weeks, that's not going to respond to thrombolytic. And again, we don't have an accurate imaging tool to assess thrombus yet. But this is something we have to consider. And whether there's clot in transit in the right atrium, this is again predictive of poor outcomes. So this is a study from Germany looking at the use of systemic thrombolysis. And despite the incidence of acute PE increasing over a 10-year period, and we know that thrombolysis is associated with lower in-hospital mortality in patients with hemodynamic instability. Only 23% of appropriate patients received systemic thrombolysis. And I think this is related to the fact that people are very reticent to give systemic thrombolysis because of the, albeit small, but potentially catastrophic risk of intracerebral hemorrhage. We look at the risks of intracerebral hemorrhage. So contrasting this to DVT, this is a scoring system looking at risk of intracranial hemorrhage following systemic lysis for PE. And they looked at a number of variables and gave them weighted them and gave them a point system. It doesn't project very well, but basically having peripheral vascular disease, a prior myocardial infarction, or being over 65 gives you 1 point. If you've had a prior stroke, it gives you 5 points. And if we just think of the vascular cohort, a lot of these patients have all of those. If you have 5 points or more, your risk of intracranial hemorrhage is 18% with systemic lysis, which is very significant. So if we can do something to avoid systemic lysis, we probably should. These are the limitations, as we've said. So bleeding from either intracranial, which is the worst case, but other GI, GU sites, access site. Obviously, these patients need monitoring in a high dependency manner. This has a significant impact. And we notice this more and more, obviously, in COVID. Efficacy, we talked about thrombus age. But if the clot is not fibrin rich, it won't respond to lytic. And again, in extensive PE, there is a theory, I think it's true, to treat the PE, the lytic needs to get to the clot. So you're only treating the edge that is exposed to blood flow. So you may only get partial treatment of the thrombus. And again, with thrombolysis, it does take time to clear the obstruction. And the longer your right ventricular dysfunction goes on, the higher the likelihood of poor outcomes is. So this is the device we use for PE, or one of the devices we use most often. It's the FlowTriever device. It's basically, like we said, a large bore thrombectomy. You put it through the heart into the pulmonary artery and you aspirate the thrombus. So a case to highlight that this is a patient who'd recently undergone a left lower lobectomy for cancer. They had a hemodynamic collapse on CT, CCU, and were empirically thrombolized for PE, which was the correct diagnosis. And then they developed profuse bleeding from their chest drains. They stabilized a little bit, so we were able to get a CT, which we can see here shows large clot burden, gross right heart strain. They came round to us, heart rate 133, blood pressure 88/60, SAT 79, pulmonary artery pressure of 42/17. So we do aspiration thrombectomy. Here's the device in the right low pulmonary artery. And following aspiration, we get an almost immediate improvement. Sorry, I'll just go back to that. With heart rate reducing, blood pressure much better, SATs better, and a pulmonary artery pressure reduction, a significant pulmonary artery pressure reduction. We don't normally get follow-up scans for PE intervention, but we did based on the cancer, and we can see there that's what a normal RV-LV ratio should look like with no residual thrombus burden. Second case, this is a 29-year-old man. He'd been admitted 3 days prior with a large central PE and collapse. Had a niggling cough for 2 weeks. And actually, when he presented, he was visiting his wife, who had just given birth. And there was this large clot burden again, right heart strain, being managed conservatively, not really making progress, then had an episode of profound hypertension on CT, CCU, did stabilize a little bit. And then we did a repeat CTA, and the clot burden was completely unchanged. Heart strain, and the CT shows these abnormal kidneys and IVC, and this is a likely source of the thrombus. So again, for mechanical thrombectomy, so that's in the left low pulmonary artery, and we can see good clearance. And this is the thrombus we extracted. So this is organized clot. That would not have responded to lytic. He only got a small improvement in his pulmonary artery pressure, but I think in these procedures, you're not looking for normalization of pulmonary artery pressure. You're looking for approximate 10% improvement in the initial stage is adequate. He was stepped down and got better. His subsequent sort of investigations demonstrated nephrotic syndrome with an increased thrombosis risk. And the question would be, should he have given thrombolysis on admission? Probably, given his presentation. Would it have worked? Unlikely. So I think ultimately he had the correct treatment. But this is just demonstrates how the chronicity of clot dictates what will respond to treatment. In terms of data, I have to be honest, a lot of the data is industry sponsored in PE. So the FLASH registry, this is looking at predominantly intermediate high risk PEs, a small proportion of high risk PEs. And this is principally to look for safety of the device. We get good reductions in pulmonary artery pressure, cardiac index, and heart rate, but no significant major adverse events. FLAME trial, this is presented at Charing Cross as well today. This has caused quite a lot of controversy. It's a non-randomized trial in 11 high-volume PE centers in the US, and it's titled a FlowTriever versus a context arm, and the decision of whether they underwent FlowTriever thrombectomy or conservative management was dictated by physician choice, often by availability. Context arm being thrombolysis, CDT, and anticoagulation. Whatever you think of the trial design, the in-hospital mortality for high-risk PE patients in the mechanical thrombectomy group was 1.9%, which is incredibly low, versus 29.5%. And in terms of primary endpoint, composite adverse outcomes of mortality bailout therapy, again, a significant better results in the thrombectomy arm, 17 versus 63.9. So the limitations are obviously the physician choice. This is not a randomized trial. This is essentially 2 retrospective registries running in parallel. But what it does show is that thrombectomy is associated with low mortality rates. And I think that's the immediate unloading of the right ventricular strain is the key thing. This is how we approach it currently. So we treat high-risk massive PEs who have failed systemic lysis, and this is a significant proportion of patients. And we do primary mechanical thrombectomy if the patients are relatively stable. So there's very different groups of high-risk PE. There's systolic blood pressure of 90 or 88, say, that's been like that for 4 hours, and there's patients who are about to arrest. And the way you manage them is very different. But if they're relatively stable, we will consider thrombectomy. If they have contraindications to thrombolysis, and again, this is a significant group of our patients who are post-op, as the first case was there. And then in terms of the intermediate high submassive PEs, if they deteriorate with conservative management and are following a negative trajectory, then we would consider intervention, and those with the more severe end of the spectrum. So again, very high clot burden, high right heart strain, but stable. And the other group to consider is those with underlying comorbidities. So if someone's got very severe respiratory disease, they will tolerate a bad PE less well, and whether intervention earlier in that group is warranted as well. It's important to remember resuscitation strategies is very different for most of the patients we manage. So what we want with a PE with very bad right ventricular dysfunction is we want fluid conservative strategy. We don't want to overfill them. We have a low threshold for vasopressors. Aggressive oxygenation, obviously, and we want to avoid intubation. If you intubate these patients, some patients have to be intubated, but that can be the catalyst for them to arrest and die. Use unfractionated heparin is preferable in high-risk PE. So logistical issues, consistent service. If you're going to offer mechanical thrombectomy for high-risk PE, you need to be able to do it 24 hours, 7 days a week. And this is where we have run into issues in that, not all of us are happy doing this procedure. Anesthetic support has been an issue as well. These patients are unstable. They need anesthetic support. They need someone that can manage their inotropes. And obviously our anesthetic teams are very pressured at the moment already. And this is adding something else into that. So we're working on that. Out of hours, again, you need appropriate support. These are very sick patients. You can't do it with yourself and one nurse. It needs a whole team. And again, referrals and education. Some people are aware of this and some people will refer. Sometimes they don't get referred and they end up on ECMO and being transferred out when actually there was potentially a window for effective treatment. So this is the future, I think, for PE. A modified PERT team, pulmonary embolism response team. This was pioneered in New York. And you need representatives from each group. Whoever's going to operate, cardiology, vascular, IR, anesthetics, ED, respiratory, general medics, hematology. And then the way they do it is they have a mini MDT regarding the management of all these high-risk PEs, and you decide on the most appropriate treatment strategy. And actually, what it has shown, the data from New York, was that you don't treat as many as you think, because actually often the decision is we'll manage them conservatively. And just to summarize, this is just looking at our venous program and where we are now. So in terms of research, we're about to start and participating in the Defiance RCT, which this is a sorely needed trial looking at mechanical thrombectomy versus conservative management in acute DVT. We are part of the Viafort venous stent trial. The BEST trial also looking at stenting versus conservative management for chronic venous disease. And there's plans to participate in the THRIVE trial, which is the thromboprophylaxis in patients undergoing superficial venous intervention. We run UK and European courses for the treatment of venous disease. And I think we probably have nearly one of the largest centres for mechanical thrombectomy of DVT. We received national referrals, and even we got one from Amsterdam the other day, so that was good, for both acute and chronic venous disease. And then we have set up, as Emma said, this ORS referral service for all acute iliofemoral DVTs, which is really good for avoiding missing patients. Thanks very much. Any questions?